back in November, we had a wonderful event with Four Seasons, and I remember talking about how lucky we were to live in this part of the world and have great lunch. And since then, we've had some challenges. I imagine if I asked everyone to raise their hand that they have been directly affected by the incidents of the last 2 months, or indirectly, or know family and friends, I get a pretty good showing in this room. I say this only because I want everyone who is a guest here today who may not be familiar with ACG 101 to understand that we are in business networking form. We are a part of this community. We have been plugged in this community now for a decade. And we too are trying to do our part and will continue to do so. So please, if you are a guest, come back, hear more from us, keep apprised of what we're up to, and we'll definitely try to do our part as everyone else is. So I just want to make sure everyone did that, and New York as well. We have some nice programs coming up before the next couple months are out. Starting January 24th down at the Lux Hotel on Sunset, our annual Women in Corporate Growth Luncheon will be taking place. And this is going to be a wonderful event honoring Teresa Tupman, founder of Blackline Systems. And I believe there's still tickets available for that. February 7th, we'll be back in this room as we look at trends in the beauty industry. It's actually the cannibalized consumer product program we used to do. We're getting a little more narrow focus on everything that's going on. And then for those of you who've been to it, March 7th, down in Spanish Hills, beautiful location, Camarillo, our annual food and agriculture event. So a lot of great stuff coming up. Keep an eye on our website. We'll have the whole calendar up there for you, and we hope to see you then. Today would not be possible without our sponsors, so I want to take a moment to thank them, starting with our founding sponsor, Wells Fargo Bank, Calabasas Capital, the California Lutheran University School of Management, CBIZ Valuation Group, Crow Corwalk, JP Morgan, Singer Lewack, Stubbs Alderton and Barclays, Thompson Colburn, and Union Bank. And I also want to have a special thanks to our newest annual sponsor, Moth Adams. So would you help me in thanking all of our Today's event is brought to us with special help from CBRE, the premium provider of ending real estate services and support to green passengers in Nelson Harbor. So would you please help me take today's talk? And at this moment, I'd like to turn the podium over to Ryan Lewitt, who's the Senior Vice President at CBRE. He is the practice leader for Healthcare Services Group here in Greater Los Angeles. And they have a team of professionals with more than 50 years experience in real estate in this industry. So, Brian.
Hi, good morning. I run a team of 5 professionals in Southern California. We help hospitals, medical groups, medical office building owners, senior housing facility owners with their real estate needs, from Santa Barbara to San Diego, from the ocean to the desert. So I only have a few minutes, so what I thought I'd do is do an introduction, kind of set the table for this all-star panel, where healthcare kind of resides here in the 101 corridor, and then just throw out a couple observations along the way. So John will tell me when 5 minutes is up. John. Okay, so first of all, the demographics. So what we did is we mapped the demographics for this area, and from pretty much in the valley to out to Thousand Oaks to the Oxnard grade there. So that's about 8% of the population, only less than half of the area. And what you can see is the demographics here are very strong. Most of the healthcare providers want to be out here along the 101 corridor, especially where all the good payers are. So you'll see that the median household very high. It's very good for providers as well as people that want to sell their homes and go into assisted living. The insurance coverage is good, so you can see that it's a high group of insurance coverage. If you look at some of the other areas in Southern California, there's nothing like this. This is one of the better areas of all Southern California. So, who are the players here? So this is according to the Oshkosh map, so the general acute hospitals in this area. And you can see, even though MPTF is on there, that they don't run a general acute hospital, that they have a skilled nursing facility. And you can see that ACA has 2 hospitals, Los Robles and West Hills. Providence has 3 hospitals in San Fernando Valley. And Encino and Sherman Oaks for Prime Healthcare. So some of the panelists will be represented here. What's really been unique in this area is the in the last 5 years, I'd say, is that the outpatient clinics that hospitals are saying, let's get off campus, let's move out. What's most aggressive out here is the UCLA Health. They were here last year, and what they've done is they've really formed a large network of multi-specialty locations throughout the 101 corridor. They're going from past here to Thousand Oaks all the way to Burbank. And you can see their locations there. And then another aggressive person or player in this industry is Providence, and they've through urgent care, they've combined with a company called Exert, and they've opened up a number of locations on the corridor. So some of these things will be touched upon in our panel, so it'll be interesting to hear what they have to say about their strategies going forward. I see more of the outpatient. I see a lot more outpatient. We see it a lot when you can find locations in retail. Healthcare is in retail, so you see a lot of retail centers. People want to go to a retail center rather than go to a hospital for healthcare, especially if it's not very serious. And then one observation I wanted to make is that with the new Warner Center specific plan, which I'm sure everybody's aware of, that they're going to build 20,000 units there of apartments and a soccer stadium and just transform the place and put all the new development in the whole San Fernando Valley into the Warner Center. There's practically no health care there. So I looked at that and I said, well, what's going on? Why isn't there any health care? And we use these demographic, psychographic called Montecito reports and proprietary to CRB. And what we see is that the scoreboard is really high there, that there's a big need for a lot of things in Warner Center. And this what it does, it measures the household income, the demographics, all the other factors, the age and income, as well as insurance coverage, and they figure out what is needed there. And you can see that it's much is needed there that it's underserved. And so maybe if the panel could talk about that area, about what's going on in Warner Center, what are plans, why isn't there anything there? It's just a one Kaiser hospital, one medical building in an area that's I think going to need it. So it'd be interesting to hear from the panelists. And I think that's a wrap. So thanks for having me, and enjoy the panel.
I'm going to ask our panelists to come up. We have a great panel with us today. We did lose one person. I wanted to acknowledge up front that Brett Candy of Cottage Health is going to be with us today. And Cottage Health is the primary acute care provider in the Santa Barbara area. And with the flooding and the mudslides, there's literally just a catastrophe at their front door. So Brett couldn't be with us. But I'm thrilled to be able to introduce a dynamite panel that we have of real visionaries and leaders in the healthcare community. So without further ado, I'm going to let me introduce the panel and then ask them to tell us just a little bit about themselves. If I can start at the far left with Bob Beecher. Bob is president and CEO. Sorry, Dale. That's a little early for me. I'm starting at the far left with Dale Serwitz of Providence, Arizona. So Dale, if I could ask you to talk a little bit about your role, your organization in the healthcare ecosystem, that would be amazing.
Very good, thank you. I'm Dale Serwitz, I'm Chief Executive Officer of Providence Arizona Medical Center. I've been actually at the hospital as Chief Executive for 21 years. Started with Encino, Arizona Regional Medical Center, our district campus is in Encino, Arizona. And in 2008, coordinated to have Tenet, which is a for-profit entity, sell the hospital to Providence, which is a faith-based not-for-profit, so kind of a unique transition as we went through that. Providence has continued to grow here in Southern California. We're in Providence at one hospital in St. Joe's, and now in Southern California there are 13 hospitals, both 6 in Los Angeles, 6 in Orange County, and 1 in San Bernardino County. Continues to grow, not a hospital environment, but I'll share with you more actually when I do go through my comments about how it's growing in the non-hospital space, medical group space, post-acute space, and how that's changing.
Terrific. All right, now to the real Bob here. Bob, CEO of Motion Picture Television Fund. Bob, can you talk to us a little bit about Motion Picture and your role there?
Sure. So, Motion Picture and Television Fund is a 96-year-old organization. It was started in 1921 by Charlie Chaplin, Mary Pickford, Douglas Fairbanks, and other industry luminaries, with the vision that the entertainment industry is filled with labor pool of freelance workers. And when you work freelance for a living, your life has ups and downs. And when you're down and need some support, then the industry should be there to take care of you. Our slogan is taking care of our own. And for 96 years, that's exactly what the entertainment industry has done. So I'd like to say to people with all of the really awful headlines about members of the entertainment industry, for 96 years it has sustained this absolutely wonderful charitable organization to the tune this year of 30 million plus of philanthropy. Many of you have driven past our campus, probably going up and down the 101 corridor and wondered what the hell goes on there. We have owned 40 acres in Woodland Hills for 76 years now. 20 of those acres are built out as a residential community. We have 250 residents there in a continuum of care, everything from independent living, assisted living, dementia care, and long-term skilled nursing. In addition to that, we've got 18 social workers out in the community, and we continue to take care of our own in really magnificent and, I think, ways that are national models. I've been an executive in the entertainment industry for 35 years, a donor to Motion Picture most of that time, both personally and through the companies that I ran, and a member of the board for about 10 years, and about 7 years ago, I left my role at Panavision, which is a neighbor in Woodland Hills. We parted ways with our CEO, and some influential board members called me, and I think they either offered me a job or told me I was doing it. I'm not sure which. And I took over as CEO of NBTF, and it has been the most soul satisfying role I've ever had in my life. So I'm really pleased to be there. And I think I have a slightly different spin on healthcare than the two gentlemen on my flanking me, so I'll be interested in talking to you about that.
Perfect. And finally, Harlan Levine, President of Strategy and Business Development and Business Ventures at City of Hope. Before I give you a chance to tell us about your role in City of Hope, I just want to acknowledge that Harlan made an incredible effort to be here, being at JP Morgan Healthcare Conference this week. And I want to personally just express gratitude for making the effort to get down here. And to everybody here, I just take this opportunity to say to ACG and everyone who came out this morning, there's a lot going on in the world, and appreciate all the effort that everybody made to be here today. Harlan.
Well, thank you. It's a pleasure to be here. My connection actually started with Cal Lutheran, one of the sponsors. I wanted to thank them as well for introducing me to this incredible group. As you heard, I'm the president of City of Hope, and I had a slide or two. Do we have them loaded just for background?
Let me
I'll talk while we wait for it. But so City of Hope is a little bit outside the map, the main center. We've been around for 105 years. We're a cancer research and treatment institution. In our laboratory, we focus on other complex diseases and diabetes. We have 3 sites in the market. Hills and Simi Valley. What's interesting, what's great about being here is this is really an incredibly pivotal time in cancer care. You have on one hand Vice President Biden's moonshot with unbelievable opportunity, with discovery, with genomics, new technology. On the other hand, we're struggling with affordability. And the City of Hope has been around for 100 years, and we really think of ourselves as in the nexus of that. We need to help bridge the gap between what people seem to be able to afford and what all the opportunity and possibilities are. So we'll continue to focus on what we have focused on for 100 years, which is delivering patient-centered care. Over the last 20 years, we realized it has to be value-based and be affordable. But we also want to make sure that innovation is sustainable as well. We want to continue to focus on discovery.
If we can actually start there, I think it would be interesting to hear, on the therapeutic side, coming from JP Morgan, can you talk a little bit about where the science is right now in terms of the work that you're doing at City of Hope?
Absolutely, happy to do that. And I paused for a second because there's really no one area to start. There's so much discovery going on in cancer today. But I think what people hear the most about is something called precision medicine or genomic medicine, and it's really amazing. So let's just define it. Everyone will define it a little bit differently, but I'll start by saying that for decades, we would think about cancer as being a handful of diseases. You either have breast cancer or you have colon cancer. But now we're discovering that cancer is really not dozens of conditions, it's really hundreds of conditions, each one defined by its own DNA blueprint. And by defining each of these cancers by a DNA blueprint, it turns out that each of those DNA blueprints have its own vulnerability. And it's our goal in precision medicine to figure out what is that vulnerability and then give the most precise targeted therapy possible. So to put that into very practical terms, if you got diagnosed with breast cancer, you would have a certain regimen that everyone would go on, even though we knew there'd be a high percentage of people that would not respond to that therapy. And all of us have been touched personally or through family with cancer. You know it's not fun to go on therapy, and it's even worse when you know that therapy has a high likelihood of not working. So precision medicine is you can do the testing for that particular cancer in that particular individual, and then based on the genetic profile, try to make assumptions about which chemotherapy regimen or immunotherapy regimen might be most effective for that patient. So it completely changes the game. The advantages of that are the ability to target therapy. The challenges are it's expensive. The genetic testing is not cheap. The new drugs are not inexpensive. And it's going to take a lot of research to collect the data to really be able to answer the questions that we all want to answer. So to tie it to JP Morgan, to actually begin to answer your question, what was really striking about JP Morgan is 5 years ago you go to that conference and you saw a handful of presentations on genomic medicine. And at JP Morgan now you can't have a session without at least one, if not two, genomic or precision medicine enterprises talking about the work that we're doing. So it's a really exciting area. So that to me is a key area. I don't want to go over on time. I will say the other really exciting area is immunotherapy, where we use the body's own T cells, your own immune response to attack the cancer. And you can imagine that's targeted, and it feels like it's going to be safer. And we have some early data, which we'll share later, perhaps, that shows that it can be very effective against certain cancers.
So I wanted to put it out to all the panelists. One of the dissonances that I find, I'm sure that I hope people can relate to, is the science advances that you're describing are wildly exciting, and at the same time, we're living at a time of profound financial challenge of how we actually deliver care at more efficiently at lower cost, and also how do we allow access when we're, to everybody, the various payer sources out there. So I want to put it out there for all of our panelists. Any thoughts about sort of how do we balance, how do these challenges get reconciled on the ground? Gail, can I start?
Sure, absolutely.
You know, part of what we're starting to see is when we see it, you know, a lot of the changes that are happening, which are kind of focusing us on looking at how we traditionally have delivered care is changing now because of the finances, and there's just no way around it. That's the reason you're seeing these systems starting to come together. You're starting to see actually other people enter the business space, CVS and Aetna coming together. You're starting to see people like Microsoft, Google, and even Amazon starting to come into the healthcare environment. So the challenge around this is that how do you get scale? How do you be able to get efficiency in your operation and yet be able to move forward in a new world? So what we've been looking at is how do you create integrated networks? How do you be able to get that level of scale? Why now Providence, let's say, has 13 hospitals, well over 1,000 physicians hired in Southern California under that purview and under the Medical Group Foundation. How do you be able to function and operate under that? So you've got to be able to kind of generate that scale, look at how we can contract differently, and be able to have business come in the door. We know that the margins have been cut, and now hospitals, by the way, which traditionally have been generally thought of as one of the healthcare system, it's really not going to be the focus of the healthcare system in the future. The hospitals are going to be a part of the system. But the reality of it is the integrated network itself is actually the system, and it's more as a continuum. And so the way that we look at ourselves in terms of how we have to be more efficient is be able to have scale, be able to deliver that across a broad spectrum, be able to deliver it efficiently, be able to partner, realize that we can't do everything and be everything to everybody. So we have to partner with organizations that do things very, very well and have them join us as part of this because, again, the network itself is what really is where our focus is, and realizing that the margins are going to get cut. So when we look at this, we're moving into this kind of an arena. Other organizations are doing that, larger organizations as well, like Cedars, like UCLA. But again, the intrusion of non-healthcare providers into this business space is going to create some other changes. And I'll talk about other changes that are actually happening, whether it be social determinants of health, whether it be digital integration, whether it be new innovation in terms of new things that are coming in. But Providence is a huge system, and it's expected that by the year 2020, 20% of the P&L that Providence is generating on a national level. Providence now has 52 hospitals and large amounts of physicians hired. 20% in the end of 2020 will come from non-traditional healthcare services which aren't even being offered to them.
So, Bob, if I can, you're in an interesting position that motion picture is a self-funded plan. You know, one of the things that often gets lost in the discussion is that nearly half of America are actually covered by employer, or still covered by employer plans. I'm curious what your perspective is on how do we reconcile the challenge between these exciting scientific advances and the cost challenges.
Yeah, so just to clarify, there are two organizations. One is the Motion Picture and Television Fund. One is the Motion Picture Industry Pension and Health Plan, and that's the self-funded plan for members of the industry who work. We call it below the line for sort of non-creative roles. That's not me. Sorry, no worries. I'm the Motion Picture and Television Fund. It's an affiliated organization. So, you know, unlike these two organizations, Providence and the City of Hope, who are direct provisioners of health care, in 2014 we came to the realization that the primary care business that we had with 6 primary care centers around the LA Basin, serving 60,000 patients, 150,000 visits, outpatient surgery, lab, radiology, physical therapy, was probably something we shouldn't be doing. And to Dale's point, as we saw other providers in the area with much bigger scale than we could ever hope to have expanding, we realized that we were doing something that others could do for members of our industry and probably do it cheaper and better. So we sold our primary care business to UCLA, and really from a CEO's perspective, from my board's perspective, allowed us to take a big focus on healthcare and move that to UCLA and focus on social determinants of health, which if you look at charts that show what are the influences on population health, healthcare is 10% of that, and there's another 80%, 10% is genetics. We haven't figured out how to do that yet, except for movies. But the other 80% is really social determinants. It's making sure that people, it's social and environmental factors. It's everything that happens to a person when they're not at a doctor's visit or in the hospital. So that's what we focus on with our industry members. It's how to keep them socially engaged at all ages. If they're not working, if they're disabled, if they're seniors. Loneliness is seen to be equivalent to smoking 16 cigarettes a day. If you're lonely, you don't have social engagement. So we have, just quickly, a program called Daily Call Sheet, where we have volunteers in our industry calling folks who have been identified as being lonely or socially isolated and engaging them in 20-minute-a-week conversations. In many cases, it's the only person that individual is talking to during the week. So you're not going to keep people healthy. You're not going to keep them out of the doctor's office. You're not going to keep them out of the hospital unless they've got some other kinds of engagement, mental engagement, spiritual engagement, social engagement, to keep them healthy. So we really look at sort of whole person care, and are focused on all of those other social determinants that we think are going to provide good health for our industry members.
So I want to come back in a minute to this population health social determinants question for all of you. But I want to, on the question of sort of the balance, coming back to this question of cost and access challenges, Arlen, I want to ask you to sort of look at it two ways for us. On an organizational level, how City of Hope is sort of balancing that challenge is one question. My second question is more personal for all of us in the room. All of us are part of different healthcare networks. There's been this whole narrowing of networks. And I'm curious if you have any advice, if you can take off your organizational hat, and just personally, how do we think about ensuring that we and our loved ones get access to the care that we need?
Great question. It actually ties in to the themes you've already heard emerging. So let me build up to that. So let me start. What I've heard so far is the value of focusing on different areas of healthcare. You heard about Dale and primary and secondary care, hospital, clinics, and social determinants and motion picture. I think we try to think of healthcare as just one topic with, there's one solution out there. And the reality is it's like you don't have the same mechanic for a boat as you do for an engine or a train or a car. And I think to begin to get at your question, Harry, we need to understand healthcare is not easy. I know who knew, but we're going to have to stop trying to make it fit into one model of a solution. So in oncology, how do you make it affordable and how do you make it accessible? I would actually argue that we as a society have to start by asking the question, do we want to continue to advance and have innovation in oncology? The obvious answer is yes, but that comes with a price tag. And I think this assumption that it's going to be cheaper from the outset is just something we need to challenge ourselves. I mean, what if it's not cheaper? Are we willing to invest to get great cancer care? Now, that being said, I'll answer the question how we're going to be more efficient and be affordable. But I just think it's a really important question to start, because we all make the assumption that the answer is yes, but society is moving and health plans are moving the other way and trying to drive affordability. The second point I would point out that the employers, you brought up the point, employers, I think, drive innovation in healthcare across the country. So if we want to have changes in the way things are going, all of you as employers should have a voice, and it's a call to action to say, I'm going to talk to my HR people, and we're getting involved in groups like this, and we're going to ask for more information, and here are our values, and here's what we want. So at City of Hope, the way we try to address this question is an ecosystem of, we started as one major center 100 years ago. 7 years ago, we were still one center. Now we have 14 community sites. We partner very well with elements of the Providence Health System here in LA. They decided that a partner in oncology was important for them, and they turned to us. But we do only the care that needs to get done at our academic center, and we try to push as much of the care out into the community where it's more accessible and a lower price point than an academic center. And as long as it's tethered to an academic center where you have that knowledge transfer and all the benefit of the innovation and the research, I think patients and society are better served at a lower price point when you have that continuum. So that's how we address it in addition to focusing on the areas that Dale mentioned in terms of just efficiency in the hospital and operations. I think for all of us, and personally, taking off City of Hope hat, and in fact, going back to the driver, what brought me to City of Hope, I'm really a managed care geek, and this being on the cancer side is new to me in the last 5 years. I think we have a challenge. All the things that I've worked on for years, and I know there are payers in the room and other healthcare consultants. I'm a big proponent of population health and narrow networks. I think they're a part of the solution. But when you narrow a network, the premise is that there's a ubiquity of expertise available. And as some things like cancer or sophisticated surgery get more and more challenging and harder to keep up in the community, the narrow network does present a challenge that you may not have the expertise that you need in your narrow network. And that's not being critical of who's in the narrow network, it's just a reality that if cancer was 20 conditions 10 years ago, and now it's 300 conditions and information is coming out every week, how can the generalists in that narrow network really keep up with the pace of change? So what I think we need to look for are benefit designs and insurance policies that do have the cost containment strategies of narrow networks and utilization management, but they recognize and are flexible that when you're really sick, when you are in need of sophisticated surgery, whether it's cardiology or neurology or cancer, or if you have a complex cancer, there has got to be a mechanism to go outside of your network and have access to the expertise that you need. It is doable, but you as employers and as individuals have to ask for it. Otherwise, it's just far easier to continue to live in the world I lived in the 90s and the early 2000s, which is everything's homogenized, it's one network, we narrow it, we save money, and we're happy. So we really need to understand the complexity of a narrow network is not a bad thing, but when you're critically ill, it may not meet all your needs.
Thanks. So I'm struggling, we have to use our time well. I was going to, Dale, I want to turn back to you first with my next question, which is, Harlan alluded to the partnership strategy, and I'm interested to hear about Providence's strategy. One thing I'm always worried about is the buzzwords and the acronyms. We hear a lot about, I always joke as a healthcare lawyer, part of the advantage we have is just being able to sort of throw out acronyms that nobody else knows and it sounds smart. But we hear a lot about we've been talking, the term population health came up, Bob referenced social determinants of health. So if you can also sort of think as you're talking about this and say a little bit more about that. And just for, I'll just add just a quick beginning. So social determinants of health, I always feel like buzzwords have a sort of, have a half-life. And we started hearing population health in the early days of the Affordable Care Act as this idea of segmenting populations. And then social determinants of health, it's a concept that's been around for decades, but we're seeing it get more and more traction. And Bob alluded to it, I think well, but the idea that the social support network, the economic stability, the environment, education have so much to do with driving healthcare. So I don't throw you a lot, but get up to you.
I think we create words, I think, just to make it seem new and fresh. And new things happen every couple of years where there's like new acronyms and new words that come out. When we talk about population health, we talk about social determinants of health. Those are the ability to manage populations, to manage, to coordinate, and be responsible for care. And so when you live in the healthcare delivery system, you're thinking about hospital care, going to a doctor's office, those kinds of things. And what you end up realizing is most of the major problems that we have don't come from just the clinical illnesses we have. Many of them are derived from these social determinants of health. So I'll give you a couple of examples about this. So we have a program called Care Transitions, where we have patients that would be discharged, but we start to see them come back to the hospital for care all the time. They were having these chronic conditions. We had one gentleman as an example that could not get his blood sugar under control. So through Care Transitions, a coach came out to his home. Went out to his home, and guess what they found? He has no refrigerator. So through this program, we were able to get him a refrigerator. And over a year, he has not returned back to the hospital, and he had come to the hospital 14 times in a year. My point is that that social determinant of health, just changing one aspect, made a huge difference in what we can do. We also know that we're dealing with other issues that are affecting healthcare, like the opioid crisis, or mental health, or homelessness. Those are all major factors that are social conditions, but result in healthcare delivery, and they're drains on the system. So we met with, had a meeting with some of our city officials. One of our city councilmen, Jen Linder, had a program where they actually put together a rig, an ambulance that will go out to people's homes with a social worker to deal with these issues. Because what they found is that there's roughly 1,700 people in LA County that are generating almost 3,000 ER visits every year. And what they're finding is these are people who chronically are calling, and really what they have are mental health issues or they're substance abuse issues. They don't need to be in a hospital. They need to be in other areas that seek treatment, but because they're not seeking treatment, they end up in the hospital. It's this vicious circle. So we're funding a project. They did it in Phoenix. It was proven to be successful, so we're working on those issues as well. So we're going to be working on those kinds of things to address some of the social determinants of health. But we've got to be able to tackle some of those issues, because when you're responsible, again, for managing a broad population, and one side, and I think Harlan really said it very well, just like you're seeing genomic therapy change the way cancer is delivered, where you're realizing one size doesn't fit all. The healthcare system is not a one-size-fits-all system either. We're going to have a myriad of different choices out there. Government wants to save money. They're going to be pushing, and employers want to save money, and they should. So we've got to be more efficient on how we deliver health care. But we also have to realize that when we're taking care of these high-risk populations that are out there, we've got to focus our energy and attention not just on the clinical delivery, but on these other factors that are affecting why people are coming into the healthcare system.
Thank you. Bob, if I can come back to you, you mentioned talking about social determinants before the program to address social isolation. Can you talk about other things that motion picture is doing to take on to take on this population more questions?
Sure. So I'm with both these guys and what they just said. So we look at our population and we look at the factors, social determinant factors. One of the issues that we look at is, do our industry members live in a safe environment? When they are discharged from the hospital or go home from work or come home, are there loose carpets on their floor? Are there trip wires, electrical wires? Do they have grab bars? So we have a home safety van that has 2 people, full-time staff, and they're going to the homes of industry members and parents of industry members to do a home safety assessment. And in many cases, putting in grab bars, giving recommendations about moving furniture around, removing some furniture, and things like that. Because you can, provide great medical care if mom comes home and she's got a lamp wire going across a space and trips on it and breaks her hip. Then all the good health care she's getting really is not particularly good. So we're doing that. We've got 3 writing programs in the community where industry members, up to 10 or 12 of them weekly in each of these 3 groups, are coming in and writing memoirs. One program is called Habits of Happiness. They're creatively engaged, they've got a social circle, and many of them are writing memoirs lives and sharing details of their lives with people they trust that they've never done before. And they're walking away, we think, healthier human beings. We've got all of our social workers in the community. We're providing $3 million of financial charitable assistance to industry members. So, if an industry member can't make a mortgage payment or a rent payment or a car payment, needs a part-time caregiver for a spouse, a partner, a parent, things like that, we're providing that support because there's nothing that will destroy your health quicker than stress. And every one of our health centers, when we operated them, and now in our partnership with UCLA has a social worker embedded in it. And very, very often our doctors realize that the symptom that the industry member is coming in to get treated is one part medical and a large part social. Something is going on in that person's life that's causing lower back pain or high blood pressure. So they're encouraged to see a social worker, and they get engaged by a social worker, and we're able to bring positive change to their lives.
So before I'm going to open it up in just a minute to questions for people. The last topic I was interested to hit was something that Brian alluded to in his comments before, which is patient engagement, right? We're living in a time when consumer expectations have really changed healthcare. Brian made reference to the trend of retailization and going out to meet patients where they are. Dale, I know you're building a new hospital. I'm curious about digital engagement strategies. I'd love to hear from each of you about how you're taking on the challenge of patient engagement.
Absolutely. We're actually in a very interesting position because we're replacing the hospital, basically, is what we're doing, which is the traditional bricks and mortar. But yet we're designing that hospital with the idea that it needs to meet the needs of a changing population and a changing environment. So we're rebuilding the hospital. It'll be a little smaller than actually the current footprint, but it'll have all private rooms. It'll be larger rooms because more care is going to come to the patient. It'll be shorter lengths of stays, more acute in terms of its time periods people will be in the hospital. But we're going to have a beautiful new, it's a $560 million project. It's an enormous undertaking, and it'll be completed in 2022. So we're redesigning it in one respect by having it still focus on needing the bricks and mortar, but a lot of those services will be done in an ambulatory and an outpatient setting, development of new office buildings around us, and even the design of those office buildings. Most of, we have 900 physicians on staff. We expect more of them will be in larger, bigger spaces. So the office buildings now need to be even designed differently. Having said that, consumerism and much more of the care is going to be focused in general, healthcare in general, on the specific consumer. So we've got to be able to reach out more to the consumer. That means healthcare is going to be delivered much more in a person's home. So we expect not only are consumers going to be able to, as you can do today, go on your iPhone and go on any device and be able to see your medical records. We expect scheduling and all of those other issues that will happen with doctors who need to see a specialist. But sometimes those will come to you. There's going to be more activity going to you in terms of that digitalization. Within Providence actually has an innovation group which has $150 million that they're developing. And most of the work is based on what a individual would address to make sure they're addressing their own concerns. So that is an example, apps on your phone. How do we expand the apps to be able to give consumers more information so they can better care for themselves? Or to have that same app be able to go to the physician's offices or anyone else, an information center that can actually see and visualize, is a patient going off kilter? So when you take a look at someone's blood sugar, there's going to be able to tap, not only are you testing your blood sugar, but you're going to be piped into centers that are going to be able to monitor your blood sugar and see how you're doing from afar and give you a text or whatever to say, hey, it looks like you're high today. It looks like your results are not where they should be. So we're seeing a transition of consumerism where individuals are going to have to be more responsible for their care and be more in control of their care. We always joke around in hospitals because we say 75% of our admissions come by the mouth. People are doing, whether they're overeating, eating the wrong things, substance abuse, alcohol, whatever it is, if people were to control those factors, they'd be a healthier person. And this shift of both digitalization, telehealth. Right now, you go into a hospital today, is one of the points. You go into a hospital and you're having a stroke. When you're having an active stroke, all of Providence now has all of their hospitals that are stroke certified hooked up to a network. So if someone's having an active stroke, those stroke readings are being read by a stroke-trained neurologist who could be based in Anchorage, Alaska, reading it when you're here in Tarzana, California, having a stroke. So we're being hooked up more digitally than ever before, and it's going to put more of the ability to control people's health in their own hands.
Harlan, any thoughts about engaging the patient in 2018?
Yeah, so a lot of it will overlap with Dale. We've done a few things. One, as I mentioned, we've gone from one site in Duarte to multiple sites because we think that access and convenience is really important. We've had a heavily laden social worker program. In fact, we publish as much in our social work and study that as much as we do on our clinical science. And you have these resources, but to ask people to drive in Los Angeles 30, 40 miles. I was going to say minutes, but that's not the same here. 3 miles. To get the benefit of a social worker, that seems counterproductive. So we've gone to telehealth as well and made those services available without making people have the inconvenience of coming in. We've also digitized our guidelines, so everyone's getting the same level of care. So there's consistency across our network. I want to pick up on something Bob said, because he's talking a little bit earlier upstream and how important it is. I absolutely agree, and I have such passion. I would love to hear more about your thoughts on that. But even in cancer, 2 interesting studies came out. One was pretty recent, within the last year, peer-reviewed journal, that turned out that people with advanced cancer, even just having tools to help people ask about their symptoms and then have their partners manage their symptoms and be able to bring visibility, it led not to better quality of life, but actually prolonged life. Better outcomes in oncology just by asking about symptoms. And then there's this other study that is a little bit older, which gets to affordability as well, which is there are certain conditions, like advanced lung cancer was the predominant one in the study, but it turned out that putting people in hospice versus active care, and people on hospice actually live longer. So there's something about listening to the patient. The affordability piece is, let's not give people treatments they don't really want. But there's something about the psychological support of the patient in where they live and what's important to them that actually is restorative at whatever level of quality of life they can have. And I think we need to build on what Dale and Bob are talking about and understand how important it is, in addition to the genomic discoveries that come from academic centers like City College.
Yeah, if I could just pick up there very quickly. One of the things that I didn't mention that is relevant, the motion picture has probably the most recognized nationally program for community-based palliative care. So we've got over 250 industry members who are receiving palliative care, not inpatient, but in many cases concurrent with treatment. They're getting, many of them, cancer treatment, and we're seeing them with a internal medicine doctor, nurse practitioner, social worker, chaplain, activities person, and nutritionist. So we're giving them this multidisciplinary care, and what we're finding is that a much higher success rate, people who are much happier, socially engaged, and have the ability to share with their families some of the concerns that they have in this disease treatment in a different environment.
Thanks.
So I absolutely agree with what you're saying.
So in our last couple minutes, I'd love if there are questions that anyone would like to share. Yeah, can you just tell us your name and organization for you guys?
Steve Elson, I'm with Casa Pacifica. So this, I don't know how relevant this question is going to be, but it gets at the issue of investing in long-term solutions solutions to health problems. If I'm an insurer, then I want to have covered lives that are healthy. I'm going to save money. I'm going to generate some net revenue. So, but as an employer, I am switching insurance companies. At Casa Pacifica, we've switched from Cigna to Anthem for our employees. Recently, a couple years ago, we switched from Aetna to Cigna. So if I'm an insurance company and I know that the covered lives, employers are 60% of the healthcare purchasing group, but if I'm an insurance company and I know that I'm only going to have this group of covered lives on average, let's say for 2 years, then what's the incentive for me to invest in social determinants, long-term research, stuff that is, in the long haul, is going to cost me and I'm not going to have the ROI. So to what extent do insurance companies, are they funding? You know, somebody who's self-insured, Bob, it makes sense. It's in your interest to keep your costs down and address these social determinant issues. Is that the case for, you know, how our healthcare industry is funded and how do we address that?
So just since thank you. So since we're recording this, so the question for any of your thoughts is the tension between investing in long-term solutions and the short-term financial pressure on payers and employers. Yeah, let me start.
Yeah, it's interesting because we have a dichotomy here, and I hear what you're saying. Just like we have this dichotomy between social determinants of health, we're very hands-on socially, and we got this digitization and innovation, which is very technical. In this situation, insurance companies are basically having expectations of hospitals, medical groups, providers in general, providers of healthcare. They're pushing it on us. So they're basically saying, you guys have to come up with these steps to make sure that we want to ultimately push that on you. So in one sense, it's not that the insurer is coming up with many of these innovations, it's they're requiring, and they're doing it through certain processes that they have to track what we do in hospitals or in medical groups or just overall providers of care. What are we doing to make sure that we're addressing that? So we're being pushed to say, if you want to have contract A, B, C, and D, you have to show us that you're at a certain level. We're still in this trend. Remember, I said earlier, we're in transition, where price is still one of the major variables. And there are insurance companies which will say price is quality, right? Lower cost means better quality, so you're a higher tier provider. Once we get to where Harlan was saying, sometimes that's not always the case. When you cure somebody, your costs are going to go down as opposed to ongoing treatments. So we have to come up with and resolve some of those issues, but they're basically saying risk is being shifted to the hospitals. And this whole issue of price competition is there until we have better statistical information to come back to people to say, hey, like we're better because of A, B, C, and D, and we can show you that we actually can save you money per life, and so forth. Because we have the same problem in hospitals. I mean, Tarzana, as an example, we've got 1,600 employees. In the system, there's 110,000, and we've now shifted to, in the last 4 years, our third insurance company that we're contracted with as a whole system. So I know that process. So this transition is going to weed itself out once we have better data to be able to reflect what improvements we're making.
Any other thoughts? Yeah, so I mentioned I'm a managed care geek. I was the chief medical officer at the United Health Group, and I ran clinical operations for Anthem before coming to CFO. So I get your question. I think it's very relevant, first of all. I guess I would answer the question in categories. On the self-insured group, it gets back to what I talked about earlier, which is the employers really need to say this is what's important to us, and the payers, you need to do, as employers need to invest in it, and the payers need to develop the programs to help support the programs that we were just talking about. On the fully insured, one could answer on a technical point, which is those people will often come back in subsequent years, so whatever investment you're making may pay off in the future. But if we live in a quarter by quarter existence, so no one's going to buy that. I think it's a really important question that we're asking, and really, I'm a firm believer in employers. I think the employers have to work together, maybe it's this affinity group or some other group, and you establish your own principles for what you expect to get from your health plan. I will tell you that when I developed products at a subdivision of United called Optum, they would sit on a shelf until an employer said, hey, that's a good idea. And then all of a sudden, United, oh, we have that, and they would implement it. I think it's really important that employers start to get involved. They recognize that for most of you, it's your second biggest line item behind salaries or compensation is health. I think Starbucks at one point paid more in healthcare than they did in coffee beans. So, employers need to prioritize this, and it is important for productivity, and it is important for attracting talent and retaining talent. And you tell the payers what you want. And one of you, unless you're GE, it's not going to be big enough to influence. But if you form a group and are willing to buy, I don't want to name a specific payer, but buy a specific payer as a group, if you provide these programs to keep people healthy and exercising and not smoking and sleeping better, by the way, the payers will respond. They want your business. It's up to us as employers to raise the expectations in healthcare and have an opinion, have a position of what you want out of your health plans going forward.
So, just briefly, we employ about 500 people at the Motion Picture. We are not self-insured. The industry health plans are self-insured, but my group of 500 is not. Many of those are work in hospitality and housekeeping. My own view, having been CEO of a bunch of companies along the way, is employers have a financial and moral obligation to keep their employees healthy, regardless if you're insurer or anything like that, particularly if you're working in healthcare, because these are the people who are doing God's work. They're the people who are helping other people with activities of daily life. They're bringing them food, they're providing them with social engagement. They're doing all the things that are so critical to getting people healthy. And it's a huge stress on them. We have a long-term care facility, and our caregivers every day are seeing one or two people die that they've cared for. So we've got to forget what our insurer is going to do. As employers, we've got to provide that kind of care.
Thank you. So I want to respect everybody's time, and we're at 9 o'clock. I'm going to ask everyone to give me a big hand for the panel.
And actually, one more. January 24th, when we broke growth back in this room on the first week of February. It's the 7th of the World Transit Duty. Everybody have a great day. Thank you so much for being a part of this.